So I'm a little bit verklempt after that last discussion, because Paul's basically given my talk now about, no, I'm teasing a bit, but we've had a day of lots of lectures and a fair amount dealing with N2 disease, or the things around N2 disease, and you've all had to bear with my voice for the whole day. So I'm just going to start off with a few words about we happy few, we band of surgeons. For you today who have listened to me, you are my colleague, be you never so vile. This day shall gentle your condition, and surgeons in England who are now abed shall think of themselves accursed that they were not here, and hold their scalpels cheap whilst speaks those who were here today. So thank you. I have no financial relationships or potential conflicts of interest to report. This is one of our icons from our institution, Charlie Mayo, one of two brothers who formed the beginnings of our institution, and I think his quote from 1926 is still valid, and that's why we're here today talking about cancer. There are things that are more destructive, but none is more feared. And you all know this, but it's a very important piece of data, especially as we fight for resources to study lung cancer. The annual deaths from lung cancer outstrip those of colorectal cancer, breast cancer, pancreas, and prostate combined. And it always boggles my mind when I think of this data, why we stand behind these other organs with cap in hand to try and get funding for our research. It is clearly an important piece. One of the reasons I became a thoracic surgeon, it's the #1 cancer to fight. And so all of you who do this, you are doing an important job. Celsus, back in 47 AD, said there are 3 ways to treat the patient with severe disease: medicine, diet, and surgery. But only surgery is successful. And again, I'm speaking to the converted here, so it's easy to say that, and with all due respect to our radiotherapist in the crowd. We're going to talk about locally advanced disease, the N2 disease, and the treatment options. Surgery alone has poor results. Chemotherapy alone has poor results. Radiotherapy alone has poor results, which argues, obviously, for a multidisciplinary approach. Again, we're repeating some things that I spoke about earlier and that others have touched on in various ways. There are the incidental nodal mets found on final surgical pathology that we are unaware of. There are the nodal mets recognized intraoperatively. There are mediastinal nodal mets documented preoperatively, either by mediastinoscopy or other modalities of invasive mediastinal staging. And then there are the bulky multi-station and clearly unresectable, or at least in this time, unresectable N2 disease. We're going to focus on the third group here, those that are documented preoperatively. And what we've done at our institution and many institutions is because of a diligent preoperative staging, we find these patients, and we've been putting them into an induction therapy protocol with a strategy to bringing them to surgery. And you can see the difference of the different single station versus multiple station, microscopic versus clinical, and the different survivals of these. So they're clearly different types of N2 disease. Again, this is the survival curves of those different N2 disease. And then the impact of induction chemotherapy. So I'm not here to give you the argument for neoadjuvant therapy, but I will sort of give you the reasons, some of the reasons why we do it. These are the survival curves back in the JCO published paper in 2000. Again, clearly when you have response to the induction therapy, your result is better. The rationale for induction therapy is a lower likelihood of resistant clones, a lower kinetic resistance, increased likelihood of efficient drug delivery to the tumor because it has better blood supply prior to our surgery. Earlier introduction of chemotherapy increases the potential for significant tumor response. Early exposure of micrometastasis to systemic therapy increases potentially the cure, even though there are micrometastases. Patient compliance prior to surgery is likely going to be better than with adjuvant therapy, and it allows us to assess the response of the tumor so that if we want to give adjuvant therapy, we may be a little bit better informed. Again, the randomized trials from way back when, as Gilbert Massard in his presentation this morning showed, a lot of the data comes from many decades ago. This is the Roth trial, again, preoperative chemotherapy and surgery, a better median survival of 64 months versus surgery alone. The Roselle trial, again, 22 versus 10 months in median survival. And then we have the SWOG trial from, again, way back when, looking at surgery versus this, and showing that surgery improves survival. The N2 patients with induction chemotherapy, 202 were operated on, 194 exclusive chemoradiation. Survival without recurrence increased after surgery, and there was increased global survival after lobectomy, which is sort of what we were talking just about in that last discussion. Progression-free survival was better in the bimodality arm. Overall survival tended towards improved survival. Then you add radiation to this. Again, the trimodality therapy was better than the chemoradiation arm. When you have the overall survival, this is the issue of pneumonectomy. The pneumonectomy ones give you overlapping survival curves. When you pull them out and do lobectomy alone, you show that, that there was improvement in the trimodality arm, including surgery. And then this is the pneumonectomy one where clearly surgery had a poorer survival. We're all aware of this, and that's why we sort of, as was said in the last discussion, try and do more parenchymal sparing operations after induction therapy. And again, not to belabor all of these same pieces of data, what we've chosen to do and what we've done over the last number of years at Mayo Clinic is to significantly search for mediastinal metastatic disease. If found and the patient is a candidate, they will go for neoadjuvant chemo and radiation therapy followed by surgery. And again, these are a lot of those studies that we've seen earlier today, and I'm not going to belabor that. Again, the lobectomy subgroup did better than the chemo radiation group. The conclusions were that N0 status at surgery predicts significantly better 5-year survival, so if they've had good response. Trimodality therapy is not optimal if a pneumonectomy is required. Lobectomy after induction chemoradiation therapy is feasible in fit patients, and control of both local failure and systemic relapse remains the major challenge. So it's within those boundaries that we choose to go ahead and operate on these patients after induction therapy. So about half of the theory is that we downstage the tumor with induction therapy. That happens in about half of the patients. That increased completion of planned therapy versus adjuvant is true. There's an increased resection rate. That's unknown. There's increased morbidity and mortality. That, again, it's plus or minus. And then there's decreased micrometastases with induction therapy. That is unknown as well. And increased survival. I think that we tend to believe that as surgeons, but we still have this controversy in those debates that get heated at our multidisciplinary conference. So what we do, I try and time it so that we have our patients returning at about 4 weeks from their last radiation dose. One of the things I tell my patients who are going into an induction treatment plan is to keep track of your schedule and let me know when the last radiation dose is going to be scheduled so that I can see them back at about 4 weeks after their last radiation dose. I think that gives me a chance to plan their surgery and get them to the operating room before 6 weeks. I think the earlier we can get them to the operating room, the easier and technically your operation is. I restage with a PET CT and MRI of the brain and either EBUS or mediastinoscopy. And we redo the pulmonary function tests with a specific focus on the diffusing capacity. In terms of the surgical considerations, I think perioperative fluid management needs to be meticulous. These are patients who seemingly are more susceptible to reperfusion injury. And there may be pre-existing post-induction pulmonary third spacing that has occurred with the development of pulmonary hypertension and chemotherapy-induced, to some degree, transient renal tubular dysfunction. So it behooves us to be very, very strict with their fluid management around the time of the operation. I tend to encourage my anesthesiologists to use phenylephrine rather than crystalloid boluses. They know my predilection for that, and so as time goes on in my practice, I don't have to repeat myself as much with them, but I still do. And the liberal use of postoperative diuretics. I think this is a very important piece for regular lung surgery, but all of these principles are even more important when we're dealing with a patient who's undergone preoperative chemotherapy and radiation therapy. Perivascular fibrosis. The radiation does cause a change in the local anatomy. There is fibrosis of both the hilar and mediastinal structures, and that increases with time. Hence, my interest in bringing them to the operating room early after radiation therapy, or at least earlier than many, to try and minimize that. We give them time after radiation therapy not for it to treat more, but for it to heal and give the chance for the patient to bounce back from their chemotherapy and radiation therapy. Most patients who are candidates for surgery will do so within 4 weeks. I have the same philosophy for our esophagectomy patients who undergo neoadjuvant therapy as well, bringing them back at 4 weeks after their last radiation dose to be assessed for resection. Again, on the topic of perivascular fibrosis, there is an obliteration of the adventitial plane around the pulmonary artery branches, and this is what makes it difficult. Again, this is a factor that increases with time, which makes so-called salvage surgery a much more difficult issue. Again, salvage surgery, I was asked to write an article about this a while back, and salvage surgery, it's a little bit in football, in American football, you have 4 chances to make 10 yards and move along. Fourth down is often a time when you give the ball up because you're not likely to make it, but some people risk fourth down. It's like, that's how I think of salvage surgery. Salvage surgery at 8 weeks is different than salvage surgery at a year or 18 months. So it's fourth down in inches versus fourth down and 20 yards. It's a different thing. And because of all these issues of fibrosis, I think it's often recommended to obtain central PA control early. If you don't get it early, you should at least get it midway through when it's obvious that you will probably need it. The bronchial stump. There is radiation vasculitis, and that causes diminished bronchial blood flow and leads to poor stump healing. That's why we have an increased rate of bronchopleural fistulas in patients who've had radiation first than those who have not had radiation. And there's multiple options. The serratus anterior muscle is one of the muscles we use a fair amount of at Mayo Clinic. The intercostal muscle is also usable, but you have to think about that ahead of time. And deciding midway through a case, especially a thoracotomy case where you've already put the retractor in and banged up the muscle, is not the time to think of using the intercostal muscle. You need to harvest it early, and you need to harvest it in a very meticulous way to preserve the blood flow so that it's not just a string of fibrous tissue in 2 weeks' time. Pericardial fat pad or parietal pleura can also be used to cover the bronchial stump or the bronchial stump, and is a useful piece. I don't think we've answered the question of whether this coverage acts as increased blood flow versus a physical barrier. Michael Mueller tried to do that a number of years ago with a study in Vienna, but I'm not sure that that actually answered the full question. It may have caused more questions than answers. In terms of pneumonectomy, it's got a poor prognosis. It's to be avoided if possible, and to avoid it, you're clearly encouraged to use bronchoplastic or parenchymal-sparing techniques. Again, after radiation, bronchoplastic techniques can be difficult or can be risky, but probably less risky than a pneumonectomy. So in terms of my take-home messages for surgery after neoadjuvant therapy, patient selection is very important. This speaks to your judgment, and every surgeon in this room, you're all surgeons, that's probably your highest level skill, higher than a steady hand. A good judgment on choosing your patients appropriately and with good evidence-based thought is always important. Never be insulted when you're up at the podium and someone questions you by saying you have a highly selected cohort. That's what you do. You're a surgeon. Pulmonary toxicity is real. It can happen. It's somewhat idiosyncratic, but certain chemotherapy medications do cause known reactions to oxygen. Preventative measures can be to use low FiO2 as much as possible. Oxygen is a drug. It has a therapeutic range, and it's especially important when you have younger anesthesia people, trainees in there who believe in oxygen as mother's milk and they just turn it all the way up. It's a real drug and it has a therapeutic range. So keeping your FiO2 during the operation as low as is necessary, as low as is tolerated is really important. And I'm okay with the liberal use of steroids. Renal toxicity of chemotherapy, it's important to keep that in mind. Some of the technical challenges, as we've talked about, it's important that if you look at some of the studies that are fairly difficult to generalize but real in high volume centers, there really is no significant increase in intraoperative complications. Postoperative morbidity and mortality can be slightly increased, but it's not statistically significant. So meticulous care can lead you to similar results as patients who have not received neoadjuvant therapy. Bronchial stump coverage is important, and anytime you've had a patient who's been radiated, you need to cover it with something. I think you owe it to the stump to do that. Wait 4 to 6 weeks for adequate recovery after neoadjuvant therapy prior to surgery, but don't wait too long. There are many brave, I'll leave you with this quote, there are many brave surgeons, but most often the bravest person in the operating room is the patient. You have to make sure that what you're doing has good judgment, that you're ready for those cases, and if you're younger, and some of the people in the crowd are younger, bring your senior person along with you. Have that support. Be in a place where you're going to have that support. We choose to go to the moon or to do N2 disease in this decade, not because it's easy, but because it's hard. And we leave you with Bob Ginsburg's quote. Thank you.